Hello, good morning, good afternoon, and good evening. I hope everybody is doing great. Today we are going to um, talk about one of the most commonly tested topic, which is very common and very commonly tested in licensing exam, regardless of which test are you applying, whether it is MCCQ1 or NACOSKI. So asthma, you would definitely get a few questions, not one, not two. So definitely it's going to be more than that, probably around 5 to 10, not 100% sure, but it's very high yield and very commonly tested. So I do encourage you guys to give it 100% focus. It's not hard, but it's a little bit tricky when it comes to management, and that's it. So the rest, I think it's pretty simple and straightforward. So the section one that today we're going to talk about is about introduction to asthma. So, introduction to asthma, the definition of asthma, I'm 100% sure that everybody knows it. Asthma is characterized by chronic airway inflammation and hyper responsiveness, leading to recurrent episode of wheezing, coughing, and difficulty breathing. This condition can significantly impact a patient's quality of life and requires careful management for optimal control. So it's something that is reversible as opposed to other conditions that we have, like COPD and so on and so forth. So it is inflammation, airway inflammation, and highway hyperresponsiveness, but reversible. All right, 10% in terms of percentage, which I doubt it if they ask you in the licensing exam. They have removed it. They're not going to ask you anything about the percentage. But still, it's good for a general knowledge. Asthma prevalence in Canada is 10%. Approximately 10% of Canadians are diagnosed with asthma, highlighting the importance of understanding risk factors such as genetic and environmental triggers. So the only thing that's essential in this slide is that we have to know that why they're commonly testing this, because 10% of Canadians are suffering from it. So it's important to know asthma, because you would get on daily basis like 10% of your patient who is suffering from asthma. So if you happen to have like 100 patients per day, 10 of them will have asthma. And that's why it makes it an important topic to know. All right, in terms of pathophysiology, again, airway inflammation, chronic inflammation of airway results in swelling, increased mucus production, and airway obstruction. In terms of airway hyperresponsiveness, exaggerated bronchoconstriction in response to various stimuli leads to difficulty in breathing and asthma symptoms. So cellular component, this will be in the licensing exam. Remember, they require you to know which cells components are involved and creating or causing asthma. So asthma is characterized by involvement of various immune cells. The key players include the mast cell, you need to know, and I'm pretty sure you guys know it by now, eosinophil and T lymphocyte, which contribute to the airway inflammation and hyperresponsiveness seen in asthmatic patient, ultimately leading to the clinical manifestation of the disease. So mast cell, eosinophil, and T lymphocyte. Please remember them because they will be in the licensing exam. Either they're going to be one of the options to choose, or they might be in the scenario, and then based on them, you need to pick the right management or treatment or medication. And probably you might ask, like, how? We will discuss it. All right, clinical presentation of asthma, common symptoms of asthma. What are the common symptoms? Wheezing, very common. Everybody knows it, and I'm pretty sure that's very common, and you don't even need a reminder on this. Wheezing is a high-pitched sound produced during expiration, indicated airway obstruction and inflammation. Cough. A persistent cough can occur, often worsening at night or early morning, disrupting sleep and daily activity. So when it comes to symptoms, wheezing, it should be on the top of our list, right? But after wheezing, it should be the coughing. The cough usually in asthma is usually dry, and they may not mention it directly, but indirectly they may mention that they cannot sleep properly due to persistent cough or dry cough. The cough is a little bit different than other condition. For example, in COPD, it is going to be very severe and it is very tiring for the patient. And you can tell that it is coming from the lower side of the lung rather than asthma, which is coming from the top side of the lung. And usually it is dry and short as opposed to COPD. Like, so it's gonna sound like this one, and it's gonna be repetitive, very dry, very short, and it's gonna be not soft but dry, but repeatedly, as opposed to COPD that's gonna be like oh, like this one, like it comes all the way from the bottom of the lungs. They might play a video, which I hardly doubt it that they give you that short video, or they may just play the sound of the cough and then they give you a scenario, and based on that, you should be able to tell this is short, dry, and repetitive, and it happens at night, early in the morning, and it could be during the day as well. But usually it is more severe at night and early morning, or the patient will wake up with it. It wakes up the patient. Chest tightness, patient may experience chest tightness, a sensation of pressure or constriction often linked to airway inflammation. Shortness of breath. Shortness of breath is common, especially during the physical exertion or exposure to non-triggers, indicating airway hypersensitivity. So in terms of exertion, probably they give you somebody that who is jogging, walking, running, exercising, and so on and so forth. Triggers for asthma, common causes and effects. It could be allergen, common triggers including pollen and dust mites. And exercise, as I mentioned before, physical activity can trigger asthma symptom as well. Physical examination finding. This is important for NAC OSCE. During a physical examination, wheezing on auscultation indicates compromised airway in the asthma patient, a prolonged expiratory phase. This is, if you notice wheezing on auscultation, I bolded, and also prolonged expiratory phase is also bold. And the reason I bolded that it is commonly tested. Wheezing, everybody knows it. But remember, prolonged expiratory phase is also characteristic finding in physical examination. You might get it also in not only in NACOSCI, but in an MCQ1. In MCQ1, they might ask you, what is the characteristic physical finding on auscultation on addition to wheezing? And it will be not on auscultation, physical examination on top of wheezing. Prolonged expiratory phase is also characteristic and suggestive of airway obstruction. Recognizing these findings is essential for an accurate diagnosis and effective management of asthma. Sorry. Diagnosis of asthma. Diagnostic test for asthma evaluation spirometry. Everybody knows this, right? Spirometry is number one. Measure the FEV1 FVC ratio for airway airflow limitation. And this is how you differentiate between the asthma and COPD, right? If you have a patient that you're not sure whether it is asthma or COPD, you do the spirometry. And if the patient gets better after the using the SABA, or a bronchodilator. So you use the bronchodilator and then check with a spirometry. If the patient improves, then the patient has asthma. If the patient does not improve, this is COPD. So provocation methacholine test. So remember, if you have a spirometry, so how they are going to test you on provocation or methacholine test. They usually give you a scenario about somebody who has asthma, and he has all the characteristic of asthma, the sign and symptoms, everything matches the asthmatic clinical feature except for the spirometry. Spirometry is normal. The patient has cough, the patient has wheeze, the patient is taking the bronchodilator but still not improving. So the patient has clinical feature of asthma, but spirometry is not confirming it. The spirometry is not conclusive. Then for confirming that, when it is normal, then you have to go for the provocation test and methacholine, which is called methacholine test. Assess airway hyperresponsiveness to a specific stimuli. Okay? But for this, remember, a spirometry has to be normal to go for provocation test. And if they want to test you on this, they will give you a scenario about somebody who has asthma, but spirometry is normal. Then you need to confirm it. How do you confirm it? With methacholine test. Methacholine challenge test in asthma. So I broke it down for you guys. What is methacholine test? A broncho provocation test used to assess airway hyperresponsiveness when asthma is suspected, but baseline spirometry is normal or non-diagnostic. So I kind of simplified it in the previous slide. So everything that was important, you know it. Now, how it works, patient and his an increasing concentration of methacholine cause bronchoconstriction, measure FEV1 after each dose. Positive test should be 20 or more than 20% fall in FEV1, which is called positive concentration 20% at the low methacholine dose. So if you have 20 or more than 20%, it means this is positive. When to use it? First, asthma symptoms presents with a normal spirometry, which I did mention it before, right? You have a patient, the patient has all clinical feature of asthma, but spirometry is normal. Uncertain diagnosis despite suggestive history of episodic wheeze, cough, chest tightness. Occupational or exercise-related asthma evaluation. But if they want to test you, they usually test you like this. They give you a picture of a scenario about somebody who has asthma, spirometry is normal. And then you will second guess yourself, like, is this asthma? You're going to doubt yourself. Then you go with a methacholine test. When not to use it? Baseline FEV1 is less than 60 to 70% predicted. Recent MI or stroke. Uncontrolled hypertension. So if your patient happen to have asthma and normal spirometry, even if you want to do this, this is not indicated because it makes those conditions worse, especially if the patient has a stroke. Severe asthma, risk of significant bronchospasm. Why? Because we are actually provocating, right? We are creating bronchospasm. If the patient is already having a severe asthma, we cannot even try it. Okay. Key interpretation points, very important for IMG. This is very important for you guys. High sensitivity, low specificity. Negative test essentially rules out asthma. That's why they call it confirmatory. Positive test does not confirm asthma alone. Can be positive in COPD as well, allergic rhinitis as well, smokers, and recent upper respiratory tract infection. So if it is positive, it is not only for asthma, not only for asthma. So it means the patient has this issue, then you have a variety of differential that you need to exclude. Examples used to rule out asthma, not to confirm it. But again, they might ask you how to confirm it. If the patient has characteristic of asthma, but you do not have exclusive spirometry result. But it's not always using for confirmation, not always, just specifically on those points. Always interpret it in clinical context. Reversible obstruction on spirometry remains first-line diagnostic test. Take home, methacholine challenge test is equal to rule out test of asthma when spirometry is normal and suspicion remains high. Differential diagnosis, the key distinguishing feature of condition, COPD. COPD is chronic obstructive pulmonary disease, typically presents with a progressive decline in lung function, chronic cough, sputum production, especially in a smoker. So if they want to test you on COPD, they usually give you someone who has history of heavy smoking. Not only that, the patient will have shortness of breath. On top of that, chronic cough, which I give you the example how it's gonna sounds like, and it's gonna be productive. So it's gonna have sputum production, and the patient is getting worse and worse and worse, and it's not reversible. And when you give him the bronchodilator, you do the spirometry, it's not gonna improve. As opposed to asthma, when you give him bronchodilator, when you check again or do the spirometry, the patient will improve. Bronchiectasis. Bronchiectasis is characterized by persistent cough with a large amount of sputum, often associated with recurrent infection and history of lung injury. Management. Goal for asthma management, symptom control. Effective management of asthma symptoms improves quality of life and reduce the frequency of exacerbation. So these are the most important thing for us to know, that we need to control the asthma. Not only that, we have to prevent the exacerbation. So if you have somebody who has asthma, who is not being controlled with the medication that you gave or you prescribe, then you have to add on something to make sure not only to control the asthma, but to prevent the exacerbation. Risk reduction, very important. Minimize exposure to triggers and proper medication use, lower the risk of severe asthma attack. For example, if you have somebody who has, let's say, aspirin allergy or non-steroid anti-inflammatory medication. For example, he takes it and then he has the asthma attack. So what is the trigger? Medication, remove it. Or if you have somebody who has asthma, but in a specific location, for example, he goes to work and then he has asthma. When he comes back home, he's fine. So he has to change the job, or at least that area that he is exposed to different types of chemicals or whatever it is. So reduce the risk or remove it. Pharmacological treatment, we have SABA, we have ICS or a steroid, then we have LABA, then we have LTRAS, and then we have IV magnesium, and then we have IM epinephrine. So for SABA, always remember in emergency condition, the first best, if they're asking you the best immediate medication, it is always SABA. So you always start with this. If the patient is not improving, then you move on to a steroid. If still the patient is not improving, then you go to LABA. But remember, LABA is not an add-on medication in emergency. LABA is more for like long-term maintenance and control. It is usually used with steroid. So you cannot use it without a steroid. So it has to be with a steroid. Okay? It has to be with a steroid. Not a good add-on during emergency visit, but as a long-term medication, it's a good add-on. So SABA, not helping, steroid, not helping, LABA, not helping, move on to the leukotriene receptor antagonist. And if they're not improving with all these medication and the patient is getting tired, not improving, moderate to severe, you give him IV magnesium, which is for severe refractory. IV magnesium sulfate after intensive inhaled therapy and steroid. Then we have IM epinephrine if you have the anaphylaxis, right? We all know that. Now for the intubation, which I forgot to put it here, if the patient has altered mental status change, if he has very high PCO2, if the patient is severely fatigued, and you know the patient is going to go to respiratory arrest, then intubation. Okay? So after magnesium, IV magnesium, The next step would be intubation, which I forgot to put it here. Anti-IL-5 therapy for asthma. What is this medication? Biological therapy that targets the IL-5 pathway, which drives eosinophil growth, activation, and survival. So just to make it simple, I will read this, but to make it very simple or simplify it for you guys, how do they test you in real exam? They give you a scenario about somebody that who has asthma. Despite using all these inhalers, despite using the SABA, steroid, LABA, and so on and so forth, the patient is not improving. And now the patient has sputum, and when you check, there's eosinophil. So if you have eosinophil in the blood, in the discharge, and the patient is only getting worse and not responding to medication, then this is going to be the best medication. Okay? So this is how they're going to test you. Who is it for? Severe eosinophilic asthma that remains uncontrolled despite high dose of steroid and LABA with a good adherence technique, usually with a frequent exacerbation, often leading to prednisone burst, and evidence of eosinophilic inflammation. Example, elevated blood eosinophil or sputum eosinophil. As I mentioned before, you have a patient, your patient is asthmatic, you're giving him the SABA, you're giving him the steroid, you're giving him the LABA, you're increasing the dose, and the patient knows the right technique to use the inhaler. So there is no non-compliance, there is no issue with the technique of using medication. So, everything is fine, but still the patient is not improving. And when you check, the level of eosinophil is very high in sputum and the blood. Then you will use this medication. Example, mepolizumab and rislizumab. These are the medication. What it improves? Mainly reduce exacerbation, decrease systemic steroid requirement, and can improve symptoms control and in the right phenotype. It is not rescue medication. Practical exam points. Consider after confirming diagnosis, optimizing inhaler technique, adherence, and addressing triggers, comorbidity typically initiated by a specialist with ongoing monitoring. Now, this is a pyramid of the treatment. I made it to make it very easy for you guys to remember, and I'm pretty sure everybody knows it. So it is easy, but it's a little bit like tricky when it comes to a specific condition. I mean, a specific scenario. Then you have to like choose either or. But normally or generally, this is the pyramid. So stepwise is you always start with a SABA, then you move on to steroid. Then if it doesn't help, then you add LABA. And if it doesn't help, then you go to medium. So increase the steroid dose. And then if it doesn't help, increase the LABA. And then add on the therapies, biological or oral steroid. Okay? So there is a note. The reason I put this note, because this might be in the licensing exam. It's a little bit tricky, so you have to know it. This is very specific. I couldn't place it in that pyramid because of the specific condition that it can be used for adolescent and adults where an appropriate formulation is available as needed. This steroid and formoterol can be used as a symptom-driven approach that improves anti-inflammatory coverage in a patient with a low adherence to daily ICA. Do not rely on SABA. So how does it help? Let's say you have a patient. Your patient is an adolescent or an adult. Your patient is the patient is not compliant with the medication. So there is a low adherence to daily ICS. If the patient is not adherent to the medication, that is a problem, right? So for that, you need something that's a little bit long term. Even if the patient is not getting the medication for a long term, this medication should be able to control it. So that's why we're not only relying on the SABA because it's short acting. I hope it makes sense. So usually they give you a scenario about, let's say, 19 years old or 16 years old, 17 years old, who has asthma and he is having so many episodes of asthma. And when you ask the patient says, yeah, I'm taking this SABA, but I'm not sure if I'm taking it regularly. So it means there's an issue with taking the medication at the right time. So for me, I have to choose a combination that even if my patient forgets it or too busy to remember it, or the patient is not a good compliant patient to medication or adherent to medication, so I have to make sure that's a long-term medication or it has longer half-lives so that it controls the symptoms. I hope it makes sense. So on that specific condition, I usually combine these two. Okay. I do not rely on SABA if my patient is not compliant with the medication. Non-pharmacological, obviously, we have to find the triggers and remove them. Allergen avoidance, minimize exposure to allergen, can significantly reduce asthma symptoms and improve overall lung function. Smoking cessation. Quitting smoking is crucial for asthma management as it reduces the airway irritation and enhance treatment effectiveness. Now, acute asthma
তারা বাসির
exacerbation.
মাঝে ভীষণ মুই মন্দা বুঝে চিরা
Oh my God, guys. Acute asthma exacerbation, recognition and management of acute asthma exacerbation are crucial for the patient safety, identifying early signs such as increased wheezing and shortness of breath allows for the timely intervention. Effective management includes using inhaler and monitoring the patient's response to treatment. I think I did cover it a few slides before. Managing acute exacerbation, we usually start with oxygenation, administer supplement oxygen to improve hypoxia, and ensure adequate tissue oxygenation during exacerbation. But remember, one thing that we need to know, we're not giving oxygen for everyone unless the patient has hypoxia. When the patient has hypoxia, then we give him oxygen. Okay? Bronchodilator utilize short-acting beta-2 agonists for a rapid relief of bronchospasm to enhance airflow. Again, if they're asking you what is the best initial or immediate medication in acute asthma exacerbation, it will be SABA. Systemic steroid, prescribe systemic steroid to reduce inflammation and expedite recovery in severe asthma exacerbation. Monitoring, continuously monitor the patient response to treatment, adjusting as necessary to achieve optimal control and safety. Asthma action plan. So, what is the asthma action plan? An asthma action plan empowers patients by outlining personalized strategy to manage their condition effectively. This plan includes medication usage, symptoms tracking, and steps to take during exacerbation, ensuring patients are prepared for various situations related to their asthma. So this is not going to be an MCQ one, but this is going to be part of your consultation for NACOSCI. So if you're doing a NACOSCI, I mean, you have asthma patient consultation. When you do the consultation, asthma action plan has to be part of your consultation. Okay? So special consideration for asthma in pregnancy and children. Asthma and pregnancy can complicate pregnancy, requiring careful management to ensure both maternal and fetal health, as uncontrolled asthma poses risk during the labor and delivery. So how do they test you on this one? If you happen to get a case about asthma during pregnancy, they would like to know if you know the right and safest treatment, which for a patient with asthma, the safest medication is a steroid inhaler. You just continue that, you do not stop it. Okay. Asthma in children. In children, asthma can significantly impact growth and development. Early diagnosis and management are crucial for minimizing long term effect and improving quality of life. So it means if you have somebody that who has repetitive cough or wheeze, you need to act as soon as possible to diagnose it and treat it, find the triggers, remove it, because the sooner you treat it, the better it is for the patient growth. Patient education, again, this is not going to be part of your MCQ one. It might be, but not very hard, commonly tested. It is more common in NAC-OSCE. Empowering patient to manage their asthma is crucial for achieving optimal health outcome. Education enables individual to recognize triggers, adhere to the treatment plan, and utilize inhaler effective. This knowledge foster confidence and promote proactive engagement in their asthma care. So these are part of the education that you need to do, or in general, if we summarize this part or this slide, it is part of the counseling station for NAC-OSCE. If you're doing the consultation, you need to cover all this. You need to make sure the patient knows what is asthma. You need to make sure the patient knows what are the triggers and the patient has an action plan or a specific action plan exclusively designed for herself or himself, and find those triggers and remove or avoid them. And the patient has to know how to use the inhaler properly, because again, if the patient even knows, they have to show it to you. Like you have to ask them, can you show me how you're using the inhaler? Even if they're like, I'm not stupid. I know you're not stupid, but I have to see it to make sure that you're using in the right way. Mostly the reason for exacerbation is lack of education or lack of knowledge about how to use the puffer or the inhaler properly. So you have to see it. If the patient is okay, then you don't have to waste your time educating the patient on the technique of using the inhaler. If not, then you have to explain it. And also, the patient has to know that how important it is for him or her to be compliant with the medication. Uh, and the complication if he is not or she is not. And utilize the inhaler, yeah, and the knowledge overall, give him a confidence about the condition that he or she has. And then the follow-up, like when does he have to follow up? So these are the things that you need to cover for consultation and NAC-OSCE. And thank you very much. This is the end of our lecture for asthma.